Couple of slides are from Envision.
The only thing to remind you is *# is your code to mute yourself if you need to.
And also the disclosures. I don't have anything disclosed except that for some of the publications that I'm going to discuss during my talk, I'm the co-author on that.
And we do want to announce we have partnered with Molina Healthcare. If you have a Molina patient that you would like to bring to clinic, any of our 3 clinics actually that we do this at, you can receive up to $150 from Molina for consulting with us on your Molina patient. And contact us for more information about that, or go to our website, envisionnm.org.
Great. Before I start my talk, do we have any cases for later on? Anybody? Somebody? Anything? Okay. I just want to see how to shorten or lengthen my talk. Great. So today we're going to talk about side effects of inhaled corticosteroids. I'm going to start actually with this slide from guidelines and the recommendation for the guidelines for diagnosis and management of asthma. As you all know, inhaled corticosteroids are more effective than any other agents on all asthma outcome measures, and they are preferred treatment for all aged patients. As you know, we have different recommendations for 5 to 11 and then 12 and up, but again, regardless of the age, inhaled corticosteroids are the most effective agents. And then alternatives to inhaled corticosteroids, I have listed here alphabetically, include cromolyn, leukotriene modifiers, adoquinone, and sustained release theophylline. So on that note, I want to show you this slide, which is one of my favorite slides, and hopefully that would emphasize on use of inhaled corticosteroids and why we are having this discussion today. This graph is from a study that was published in New England Journal of Medicine in 2000, and it shows that low dose of inhaled corticosteroids can actually prevent death from asthma. That this was a population-based cohort study that was done in Canada, and subjects from 5 to 44 years of age on anti-asthma medications from 1975 to 1991 were sort of kind of included in this study, and they were followed until 97. During this time, there was 562 deaths. And out of that 562, 66 of them were due to asthma. So they picked that information from those 66 patients, and they found a control group for those patients. And they found 2,681 controls for those matched to those people who had died, and they looked at the difference between them. And what they found was that, first of all, 50% of each group, those who had died and those who were still alive, they were on inhaled corticosteroids. So there was no difference on management of asthma in these both groups. What they found was that the mean canister of inhaled corticosteroid used in the group who had died was 1.18 versus 1.57 in the group who were still alive. So after you do this data analysis, you can actually translate that to the rate of death from asthma was decreased by 21% with each additional canister of inhaled corticosteroids, which I think is very significant. Another way to interpret this result or to present it is to say that the rate of death from asthma among users of inhaled corticosteroids compared to non-users was reduced by 50% if they use more than 6 canister of inhaled corticosteroid every year. They don't even have to be 100% compliant or 90%. 50% compliance in 1 year reduces the rate of death by 50%. And again, this is exactly what this graph shows. As you see in the y-axis, we have the rate ratio for death from asthma, and then in the x-axis, we have number of canisters of inhaled corticosteroids per year. As you decrease the number of canister, as you increase the number of canister, you actually decrease the rate of death. So that was very significant, and actually that shows why it's important to know about inhaled corticosteroid, to dose the patients, be aware of side effects, and be able to respond to the patients. In our presentation today, I'm going to refer to CAMP trial a lot, so I thought I'm going to give you an overview of this study. CAMP stands for Childhood Asthma Management Program, and it is the longest and the largest prospective trial in asthma that has ever been done. Albuquerque, we were one of the centers. There were 10 centers, and more than 1,000 children aged 5 to 13 years old were recruited for this study. And that happened over that happened over 93 to 95 recruitment of the patients. Then, after patients complete the screening and baseline, they were randomized to 3 different treatments, either budesonide, 200 microgram, 1 inhalation BID, placebo, or nedopramil, 8 milligram BID. Patients were followed for 4 to 6 years with frequent visits and asthma monitoring. If they had any exacerbations, prednisone was given to the patients. If they were not controlled on budesonide, another inhaled corticosteroid was added to the regimen. And then after 4 to 6 years, which was the mean years of 5.3, study was stopped. Okay. At that point, we published our results, and I'm going to show that to you in New England Journal of Medicine year 2000. After that, we got more funding from NIH to follow these patients to see what happens to them as they grow. During that time, the transition and the follow-up phase of 13 years, we did not provide any medication. We were just following the patients. They were seeing their own PCP, their own physician. We were just collecting data, and we were measuring their lung function, and we were measuring their height. I'm mentioning these things because we're going to discuss these later on. So one thing I want to show you is the result of CAMP when we look at the efficacy of inhaled corticosteroids. So subjects who were randomized to budesonide compared to placebo had a statistically significant difference in the decreasing airway hyperresponsiveness. They had 43% fewer hospitalization, 45% fewer urgent care visits, 43% less prednisone use, less rescue albuterol, fewer symptoms, and more episode-free days. Again, we published these results in New England Journal of Medicine in 2000. Again, I just want to emphasize the importance of inhaled corticosteroids as we're going to start talking about side effects of it. Because like any other medication, we have to consider pros and cons, and we have to monitor our patients. So let's talk about systemic effect of corticosteroids. And again, please note that here I'm referring to corticosteroids, and I'm not talking about just inhaled corticosteroid. This is in general talking about PO, oral medication, as well as inhaled corticosteroids. In short term, what you can see is atrial suppression, hypokalemia, hyperglycemia, psychosis, weight gain, glaucoma, and decreased bone density. Long term, you can see a decrease in growth, cataracts, adrenal insufficiency, Cushing's syndrome, dermal thinning and bruising, osteoporosis, and fractures. So we're going to talk about this in more details. One thing that I want to mention, and I'm going to repeat myself many times, is actually the fact that all of these adverse events are dose related. Okay? So here in this graph, I want to show you what does therapeutic index mean, because again, you're going to hear that a lot, and every single literature you pick up, it talks about therapeutic index when it comes to inhaled corticosteroids. Therapeutic index for any medication is when we look at the efficacy and toxicity of a medication, and we decide if it has a high therapeutic index or if it has a low. So again, in the x-axis, you see a dose of the medication, and in the y-axis, we have probability of the effect. Okay, The green curve shows efficacy. So as we increase the dose of the medication, right, we are increasing efficacy. At the same time, red curve is showing you the toxicity. Again, as we increase the dose, we increase the likelihood of having toxicity. Therapeutic index is actually the line that you will see between the red and green curve. And therapeutic index is when at a dose of 100, you have a lot of efficacy and you have minimal toxicity. And as we increase the dose, as you see this line gets narrower, means therapeutic index gets smaller. Again, this is very important for us because as we go up on the dose, we are increasing toxicity. So we need to always keep this in mind, which medication may have higher therapeutic index if we have to go up on a dose of any medication. Pretty much these curves, you can see them for any single medication. That always applies. So when we talk about therapeutic index, again, we talk about efficacy and we're talking about toxicity. And when we talk about inhaled corticosteroids, we know the main reason for having side effects is the systemic absorption of inhaled corticosteroids. So let's figure out how the systemic absorption happen. So when a medication is inhaled, part of it goes to the lungs. Great, that's what we want, right? Because lungs are site of action. But a portion of the medication, which is can actually be about 80% or so, it's swallowed and it gets into stomach in the GI tract, and from GI tract goes to the liver. And if it is not metabolized by first pass effect of the liver, it's going to eventually make it to systemic circulation. Whatever is absorbed in the lung also makes it to systemic circulation. So this is the medication, this is the portion of the medication can actually cause side effects. Of course, the best drugs are those that we get a lot of the drug in the lungs, and if the drug stays in the lung for a long period of time, that's another positive for that particular medication. When it comes to portion that is being swallowed, again, as I mentioned, for most of the MDI, 80% of the drug is actually swallowed. How can we decrease that? How can we decrease this oral deposition? That would be with devices such as spacers that we use, because that will definitely decrease deposition in the mouth. So again, keep this picture in mind, because when we talk about therapeutic index, we talk about toxicity, and we talk about different formulation, this is exactly how things can differ. If a drug has a first pass effect, a high first pass effect, that means it gets metabolized before it makes it to systemic circulation. So that is a big plus, that's a big advantage. Here is an example of how therapeutic index comes in the picture. If you look at this picture, we are actually comparing prednisone, the oral dose of corticosteroids, to budesonide, which is the inhaled corticosteroids. And if you see again in the x-axis we have the dose, and the y-axis we have, in the first graph we have asthma symptoms per week. So with the same dose, actually if you look at the effect, for example, let's say we want to have only 2 days of asthma symptoms per week, you can actually have that effect with budesonide, also with prednisone, but the dose difference is 35 times. So this is how we are actually changing therapeutic index, because we are getting the same effect but with a smaller dose. And if you look at the next graph that shows serum cortisol and it measures systemic circulation, you have decreased the systemic absorption by 7 times by using a budesonide medication, or inhaled corticosteroids, which in this case is budesonide. So you are having the same effect with less toxicity when we switch from oral prednisone to inhaled corticosteroids. So this is an example of how therapeutic index come in the picture. So factors that will determine the therapeutic index of inhaled corticosteroids are lung retention, which is the lipophilicity of inhaled corticosteroids. Those who are more they have higher lipophilicity stays in the lung for a longer period of time, which is great because that is the site of action. Rapid systemic clearance, that will be the metabolism of them through systemic circulation. Oral absorption, as I mentioned, is the first pass metabolism. If a drug has a high first pass metabolism, that's great because it never makes it to systemic circulation. And delivery system. When we talk about delivery system, we are talking about dry powder inhaler versus MDI. We are talking about use of spacers. We also talk about patient's ability to actually perform and use dry powder inhaler or use MDI with a spacer or without a spacer. So these are everything that would determine therapeutic index. And in the next couple of slides, I'm going to show you examples of how these factors may play a role in the position of the drugs in the lung. This is a great picture. As you see, we have 3 different inhalers here. One of them is Q1, which is HFA beclomethasone. Then we have CFC, fluticasone, and CFC beclomethasone. Again, the medication was radio-labeled, as you can tell, and after it was administered, equal amount of each of them, 50 microgram per puff, in healthy volunteers, we looked at deposition of medication in the lungs and oropharyngeal cavity. So with Q1, which is HFA beclomethasone, you'll see that about 50% of the drug is deposited in the lungs, and it actually gets in deep inside the lungs in a small airway, compared to fluticasone, which is only 13% in the lungs and 80% in the oropharyngeal cavity. And compare that to beclomethasone CFC, it's only 4% in the lungs and 90% in the mouth. So this slide demonstrates a few things. First of all, the difference between fluticasone and beclomethasone. It also shows you the difference between HFA beclomethasone and CFC beclomethasone. Why is it different? Because HFA beclomethasone is actually a solution. So when it is used as an agent, the particles become smaller, so they get deep inside the lungs and they make it to the small airways, compared to CFC, which is actually suspension. And the particles are bigger, so they do not get deep inside the lungs. Another example that I have for you is actually a combination of results of 2 studies. And again, as you will see, we have different agents, we have different inhaled corticosteroids, and we have them in CFC or HFA formulation or dry powders actually. So like the first one is beclomethasone, the dark blue is HFA, and the lighter one is HFA. And the y-axis you have percent of the dose which is delivered to the lungs. As you see, HFA formulation deposits more medication in the lungs. Okay, same thing with fluticasone. As you will see, CFC versus HFA has better deposition in the lungs. This is budesonide. The next one, the next column is budesonide dry powder, and the one after that is fluticasone dry powder. Then fluticasone MDI with CFC and HFA, and you can see the rest of them, mometasone and cyclosanide. Again, this graph shows you the difference between CFC HFA as well as dry powder inhalers and MDIs, and different type of agents, fluticasone, mometasone, cyclosanide, and budesonide. And again, we are looking at the dose that has been delivered to the lung. Please do not mistake this with efficacy. All we're talking about is the position in the lung. It may mean efficacy, it may not. We may need a smaller dose of one in order to provide the same efficacy as the other. All it's telling you is the position in the lungs.
And this is just an MDI versus a DPI. And were there valve holding chambers?
No, without spacers.
Just
yes.
without spacers.
Yes. So again, as you see, there is a lot of variables. When you look at the studies and when you look at the agents, you have to consider all of those things. And on top of that, you can add patient factor, right? Pediatrics versus adults, and the technique and everything. So on that note, I'm going to talk about some of the problems with babies, because when we talk about these medications and all, and the technique and what we use, we have to keep babies in mind because they have their own criteria. So with babies, the problem is they have a smaller, tighter volume, they have rapid respiratory rate, they cannot hold their breath after when they use the medication, they have short attention span, they have lack of cooperation, they are nose breathers, and they don't put that thing on my face. They do not like either the air chamber with face mask or the face mask from nebulizer, and they also have a smaller airways. So here is another one that I really like. Most of the time when these babies are sick, they're crying the whole time. And now on top of that, you're going to put this spacer on top of their face because we're going to give them albuterol, right? So look at the lung deposition when patients are not crying and then they're crying. When they're not crying, the medication actually makes it to their lungs, right? When they're crying, it goes all the way to their stomach. I love this slide. It definitely shows how it makes a difference when administered a drug. So here's another slide that I want to share with you again with babies. I have seen that a lot in our clinic that with nebulizers, a lot of parents do blow by, and that is when they hold the mask or the mouthpiece in front of baby's face. That is a big no-no when it comes to asthma management. From we see that a lot. So this graph is on the x-axis. You can see the distance of the mask from the mouth. On the y-axis, again, you can see the dose that has been delivered. If it is 0 versus 1 centimeter distance, again, the mask from the mouth, you lose 60% of the medication. And if it is 2 centimeters, you are losing 85% of the medication. So make sure they keep it close. They actually wear the mask, so we have that 0 distance between the mask and patient mouth. So I think now we can talk about specific side effects of inhaled corticosteroids. So the previous slide that I showed you, it listed side effects of oral and inhaled corticosteroids. So I'm going to focus on inhaled corticosteroids and their side effects. So let's talk about the local side effects that you will see is oropharyngeal candidiasis and dysphonia. And when it comes to systemic side effects of inhaled corticosteroids, we're going to talk about HPA axis function, we're going to talk about bone metabolism, the effects on the eyes, and linear growth. In our clinic, what we get asked the most is that last one, the linear growth. So we're going to talk about this in more details. So let's talk about local side effects of inhaled corticosteroids. As I mentioned, it is oropharyngeal candidiasis and dysphonia. Both of them are dose dependent. Dysphonia has been reported in 5 to 20% of the patient and is mainly due to local corticosteroid induced myopathy of the vocal cords. How can we prevent that? By use of spacers. Because when you use a spacer, you are decreasing the position in the oropharyngeal cavity, right? So as a result of that, you're not going to see those problems. What we recommend to our kids in our clinic is to leave their inhaler and spacer next to their toothbrush. So they use it and then they brush their teeth. So that is our way. Hopefully they remember to do both, to brush their teeth and use their inhalers every day. So let's talk about now systemic effects, and we start with HPA axis function. So what is the effect of inhaled corticosteroids on HPA axis suppression? Again, as I mentioned before, it's a dose-dependent phenomenon. In one of the studies, when they use different inhaled corticosteroids and they measure the effect of it on serum cortisol, they enrolled 156 steroid-naive asthmatics, and every week they doubled the dose of inhaled corticosteroids. They want to see how would that affect the serum cortisol from baseline. So as you see, and I have the name of all the inhalers that they were studying, what I want to show you here is that, again, as low doses, you do not see that much of a suppression. It's about 90%, and there is not that much of a difference between different inhalers. Even when you double the dose, again, you do not see that much of a difference between the inhalers. And then when you go up on the dose, as you will see, and the white is placebo, so you can compare it to that, you see that we notice suppression. One thing that I want to bring to your attention is actually dry powder fluticasone. As you will see, even at high doses, it does not cause a lot of suppression in serum cortisol, meaning it does not have a lot of systemic absorption. So this was a short-term kind of effect, right? Every every week we double the dose and we looked at the result on that. What happens if you put a patient on inhaled corticosteroids for 6 months, for 1 year? Is there a cumulative effect if they are on a dose for that period of time? Short answer is no. And that was presented actually as one of the results of CAMP project. In the CAMP, patients every year, we measure the serum cortisol for 3 years to see if there is any effect with long-term use of inhaled corticosteroids. Again, these patients are using Pulmicort 200 microgram BID. And as you will see, this straight line shows you there is no cumulative effect. And serum cortisol stayed the same during the study. So in CAMP study, we also looked at oral prednisone bursts, right? Because we also managed the exacerbations during this study. What we found is that 4 bursts or less also was not associated with any suppression in serum cortisol. Okay. So this next slide again presents the same result as we discussed, but I just want to show you how this can be dose related. This is in the x-axis we have placebo, beclometasone, and fluticasone. In the y-axis we have urinary cortisol. In the placebo, as you can see, there is no difference when we double the dose every month. And actually, the dose was started with 500 microgram, then purple is 1,000, and then 2,000. With beclometasone, 500, 1,000, 2,000, doubling the dose every month. As you will see, you cause suppression. You are decreasing urinary cortisol, meaning you are causing suppression. Fluticasone, again, the same doses, 500, 1,000, and 2,000. There was no difference between 500 and 1,000. And then at 2,000, you start seeing suppression. You are seeing suppression. And the asterisk actually demonstrates the statistically significant difference compared to placebo. Again, this slide presents the difference between 2 different agents, fluticasone and beclometasone. It also shows you how this effect, the suppression, can be dose related. The next side effect that we're going to talk about is the effect of inhaled corticosteroids on bone mineral density. What is that effect? And when we talk about this, we have to think about 2 things, osteopenia and osteoporosis and fracture, right? So the effect of bone mineral density for high dose inhaled corticosteroids can reduce bone mineral density and increase risk of fracture in older patients at risk. In kids, the data is less clear. However, studies have shown if you use low to medium doses of inhaled corticosteroids, bone mineral density doesn't change.
Regardless of age group.
Exactly. Short courses of oral prednisone have been associated with a dose-dependent decrease in bone mineral assertion and an increased risk of osteopenia if patients have used at least 2 bursts per year, and fracture if they have used 4 or more bursts per year. So I'm talking about these bursts of prednisone because I know there are some providers who believe in giving bursts whenever it's needed instead of giving that 35 times smaller dose of inhaled corticosteroid. So that's why I bring these things to your attention to know when we say the goal of asthma management is to decrease these bursts, there is a reason. There is data to support use of inhaled corticosteroids, which can be safe at small doses, at lower doses. But if we keep giving these patients bursts of prednisone, we are increasing the risk of having problems. So here is a result from CAMP. As you will see, again, this is for bone mineral assertion and osteopenia. The first column talks about the cumulative cumulative bursts, oral corticosteroid bursts. And when patients had 5, actually males, when males had 5 or more bursts, there is a chance of osteopenia. The risk of osteopenia becomes significant. We did not notice that for females. Yeah, I'm sorry. So we are talking about the first set of information is for bone mineral assertion, and the second set is for osteopenia. For osteopenia, again, in male, if they have 5 bursts of prednisone, that is associated with an increased risk of osteopenia. We saw that in males, but we did not see that in females. So what about osteoporosis and fracture? A meta-analysis of 9 prospective studies in adults with a median duration of 3 years using inhaled corticosteroid showed that there was no difference in bone mineral density of these patients compared to control. So that was not significant. Case control study of more than 16,000 patients with fractures reported increased risk of fracture from inhaled corticosteroid use. However, when restricted to those patients with no oral corticosteroid use, it was not significant. So again, oral corticosteroids, the prednisone bursts, can cause osteopenia and osteoporosis when they are used frequently. This is a result from CAMP. In CAMP, we did DEXA for the patients, and we measured bone mineral density. And as you will see, in the budesonide group, metoclopramide and placebo, there was absolutely no difference. What about the effects of inhaled corticosteroids on eyes? Well, again, in CAMP trial, we looked for that. We looked for that at the baseline, and we repeated the eye examination every year, and we did not see any children having posterior subcapsular cataracts, which is supposed to be the most common kind of a cataract seen with inhaled corticosteroids. And we repeated that at the end of the trial at 40 years when we stopped the intervention trial, and again, we did not see anybody with that kind of a cataracts. We had one patient that had received inhaled beclomethasone for 13 months on top of Pulmicort, oral prednisone for 38 days during this study, intranasal corticosteroids, and there was a questionable posterior subcapsular cataracts, but then when they repeated the examination, that was not the case. So again, it seems like low to medium doses of inhaled corticosteroids should be safe. Now let's talk about inhaled corticosteroids and their effect on growth. Actually, after we published this, last month I did an editorial on the use of inhaled corticosteroids in children makes them shorter adults, and the topic apparently did a lot of people were interested just reading the subject as upcoming editorial and waiting to read this, because I think that is a question in mind of a lot of providers. And this is one question that I can tell you I get asked all the time in the clinic. So again, you have seen this slide before, but I want to show you how we have come up with the conclusion that I'm going to tell you about. Again, this is CAMP, right? During the treatment phase, we treated these kids with budesonide for 4 to 6 years, or placebo or metoclopramide. Then we stopped the treatment, and patients were under care of their own providers for 13 years. And that was when we did the analysis again to see how much they have grown. So at this age, during the treatment phase, we were measuring their height, and I'm going to show you the data on that. And then at the follow-up phase, after 13 years follow-up, again, we have the data on their height, because we were seeing this patient every year when we were measuring them and their height with a stadiometer 3 times until they are within 5 millimeter, and we have reported those. We have a data for that. So that's why this is actually the only prospective trial that measures height of the patients when they were using inhaled corticosteroids as kids, or we knew for sure they were using that. So this is the result at the end of treatment period, after that 40 years that these kids were under our care. So the y-axis shows the growth rate, centimeter per year, and the x-axis shows the years they were in the study. The green line is budesonide. As you will see, in that first year, these kids grow about maybe 5.3 centimeter. However, those on placebo or on metoclopramide grow like 6 centimeter. So there was a difference right there. Same thing as, close to 1.5, 2 years. So what we noticed is that in that first couple of years, the rate of growth was slower. But then after that, it was the same, right? So what we concluded with our first publication in 2000 in New England Journal of Medicine is that, yeah, we did notice this difference in growth of about 1.2 centimeter at the end of the trial. Now, question is, are these kids are gonna go more until they obtain their adult height, or are they gonna stay 1.2 centimeters shorter? So that was actually, I think, the main reason NIH funded us to follow these patients and come up, have the answer once and all. At the same issue and the same journal in 2000, New England Journal of Medicine, Agertoft and Pedersen published another article about long-term inhaled budesonide on adult height, and what they concluded at that time was that yes, there is a catch-up, and kids are going to have the same height as their sibling and as control group. But this was not a randomized trial. Patients were not followed retrospectively. It was an open label looking at patients who were on inhaled corticosteroid, on budesonide, and just comparing their height to their siblings and control group. So again, I'm just showing this to you so you would know the difference between a randomized trial and a prospective trial compared to a case control like this one.
Did they also use the expected height of their parents, or was it just their siblings?
Yes, they did.
Okay.
Yes. So when at the end of 13 years follow-up, when these kids who were enrolled at the age of 5 to 12, now they were 25, they had mean age of 25, we ended our study, and here is the data. Again, in the x-axis, we have total number of patients, which was about 900 of that original 1,000 patient that we had enrolled. This is quite impressive, if I may say. And you see the result separately for males and females. So again, the group on budesonide compared to placebo stayed 1.2 centimeters short. So there is no catch-up growth. The effect was more pronounced in females, thank God for high heels, at 1.8 centimeter, and for guys for 0.8 centimeter. So that was actually, that report, this result made it to the media, from Good Morning America to Today, to everything about asthma medication stunts growth. But come on, it's 1.2 centimeter. And the prize for that is being able to breathe and exercise and have other activities in place.
And
so you have to put these things in perspective.
And being one of the survivors on the first chart.
Thank you. Yes, exactly. So the conclusion for CAMP was the initial height decrease that we saw, which was about 1.2 centimeter, associated with the use of inhaled corticosteroids in pubertal children, persists as lowered adult height, but it is not progressive and it is not cumulative. So we saw that effect that first 2 years and it stays the same. Further, when we look at the data, and we looked at association, we found that associated with lower adult height is Hispanic ethnicity and female sex, as I showed you, higher Tanner staging, lower height, greater BMI, longer duration of asthma, skin test reactivity, vitamin D insufficiency at the time of entry into the trial. That means when they were 5 to 12 years old. It was not associated with asthma severity or use of prednisone in prior 6 months, or inhaled corticosteroids prior to 6 months at the time of entry to the study. Okay? In this slide, I just want to bring that to your attention, especially for the providers, because as I mentioned so far, and I hope I have at least made that clear, all these systemic effects of inhaled corticosteroid is dose dependent. There are many reports of drug-drug interaction, especially with fluticasone, budesonide, cyclophosphamide, and mometasone, because they are metabolized by cytochrome P43A4 isoenzymes. And if patients are on potent inhibitors of CYP3A4, such as ritonavir and ketoconazole, that can actually decrease clearance of inhaled corticosteroid. As a result, you increase bioavailability of it, increase systemic absorption pretty much. I mean, it stays in the body for a longer period of time. As a result of that, you can have major side effects. There are reports of clinically significant Cushing syndrome and adrenal insufficiency, but it is because of drug-drug interaction, and it is not because of inhaled corticosteroid per se. Okay, so please do make a note of this. This is almost toward the end. I just want to bring this to your attention that when we talk about these side effects, again, it is dose dependent. This graph shows budesonide on the x-axis and the lower x-axis, and fluticasone dose and the higher x-axis. At the y, you have percent of maximum effect per asthma. And the graphs, different colors, shows you peak expiratory flow, beta agonist, nighttime awakening, and major exacerbations. So these are, as you will see, at the dose of 200 to 400 microgram of budesonide or 100 to 200 microgram of fluticasone, you're going to have the maximum effect. So why should we go up on the dose? And why should we increase the chance of having side effects? So the point I'm trying to make here is that we can manage our patients with low to medium doses of inhaled corticosteroids, and please let's keep that in mind, because all of the side effects are dose related. So these are my last words. I believe it is my last slide. Remember, if administered in high enough doses, any inhaled corticosteroids can produce clinically significant systemic effect, but there is absolutely no need to use these high doses of inhaled corticosteroids. Inhaled corticosteroid provided in the medium doses can produce HPA axis suppression, but clinically significant effect is unlikely unless we are using high doses. Again, it is very unlikely to even need to use high doses of inhaled corticosteroids. The data support growth retardation, not suppression, in adult heights of children who were treated with inhaled corticosteroids. However, the effect is sustained and not cumulative. And it's all about pros and cons. The growth effect may be reduced or even eliminated with appropriate selection of inhaled corticosteroids with highest therapeutic index, and considering different approaches in managing patients with mild to moderate asthma. And what I'm talking about here is addition of a LABA, a long-acting beta agonist, in order to keep the dose of inhaled corticosteroid lower, close monitoring of the patients frequently to adjust the dose as needed, to increase or decrease the dose, and also to find the medication that works better for the patient when it comes to the technique, which one they can use. Again, the close-up follow-up of children, and finding the lowest effective dose of inhaled corticosteroids are the bottom line. And if we do those things, we can do a better management of their asthma while we are minimizing the risk of adverse events. And with that, I open to questions.
This is Michael Lentz. I apologize for my voice. I'll try to get this question out. It goes back to the first part of your talk, and thank you for your talk. It was very good. It seems to me that you made a point for using QVAR because it absorbs, the deposition in the lungs was really significant. I think you compared it to fluticasone. But then you said that the deposition that was in the lungs did not equate to the efficacy of the drug. Also, another slide you had was the QVAR suppressing the cortisol of the... So exactly. I guess my question is, I mean, I feel that you made a point to use QVAR in low dose because the absorption is better, but you said also the efficacy isn't better. Do you have a favorite inhaled steroid? And those are my questions.
No, I don't, or I would have reported that in my conflict of interest. No, we do not. I do not have a favorite one. To be honest with you, in the clinic, the way we decide which inhaled corticosteroid depends on patient's insurance. You just have to see what is covered, and that is usually what we use. What we know is that all inhaled corticosteroids, if you use them in low to medium doses, we can see the efficacy. So that should not be an issue. But when we have a choice, we do need to look at the side effects of them and see how can we minimize the dose. The slide that I showed you with QR showing lung deposition, we were giving the same dose, 50 microgram, and we were looking at lung deposition by using radio-labeled medication. Again, if you deliver a lot of drug in the lungs, all of that drug is going to be systemically bioavailable. So that means you're actually, with QR, you can have higher systemic effect. So here it becomes the efficacy versus toxicity issue, right?
Right.
So again, what we can do is just monitor our patients and see which one works, better for the patient and how they respond to it. We should also keep this in mind that we may not need a lot of drug to be deposited in order to see the effect. Just more drug being deposited, or an agent like budesonide having high lipophilicity, that is something that you hear a lot from AstraZeneca, meaning that the drug is going to be in the lungs for a longer period of time. It doesn't necessarily mean more efficacy or a better effect compared to other inhaled corticosteroids.
That doesn't seem logical to me. More drug in the lung, that's where you want it. You want it in the lung, and you don't want it in the mouth. You don't want to swallow it. So,
but all the medication that gets into the lung is actually systemically bioavailable. It gets to the blood circulation, and it is now systemically bioavailable to cause side effects.
But also more available to the lungs.
Yes, but also more side effects. So that's why the question is, how much of a drug is enough in order to cause effect? If you can have benefit of aspirin for cardiac problem with 81 milligram, why should you take 325?
Okay.
It's the same concept.
Okay. One other question with this, the urban myth, or what I've heard, is that it's better to give multiple doses of a lower dose inhaled steroids than a higher dose steroid, for example, of 144 than one of the 110. Do you find that with regards to the technique, it's better to give multiple low dose than one larger dose?
Oh, I see. You mean 2 puffs of 44 twice daily instead of 1 puff of 110? No. There are no studies to compare that, but I don't think there is any difference. Nobody has done this study, but I know physicians do that, and the reason behind it is 110, 1 puff BID, and then they tell the patients, if you started having problems, go up on the dose and do 2 puffs BID. That's why they give them the higher dose 1 puff BID with instruction to the patients to go up on the dose because they're going back to school or it's their allergy time. So they do that so patient will have the higher dose in hand if they have to go up on the dose. It's not really to replace 2 puffs to 1 puff. And if you think about patient compliance, actually changing from 2 times to 1 time doesn't change 2 puff to 1 puff, doesn't change compliance. So that there is data for.
Okay, thank you very much. I appreciate it.
No problem. I'm personally a little bit biased toward doing 1 puff BID because I think, especially if they're using an inhaler, if they do not have the best technique, they have lost the whole dose. I prefer to do 44 2 puffs BID. So if the first puff didn't make it all the way through the lungs, at least the second dose will. But that is my personal bias. Any other questions?
I have a kind of a very specific question, but you compared deposition of beclomethasone in a solution compared to beclomethasone in suspension.
So, yes, HFA formulations are solutions.
So is...
And CFC is suspension also. Yes.
CFC is suspension. So as a pharmacist, does it, do you have to shake a suspension and a solution equally? Or does it matter? If it's HFA and it's solution, can you...
So with HFAs, I think in the instruction it says if you haven't used it for 6 or 7 days, you actually have to prime it again and all of those things. Why do they do that? Why do they say that, but they don't say it about CFC? Because we do not have that for CFC formulations, right? The reason is when they were doing this study, that's how they did it. So that's what they have to put in package insert. Now, if after 7 days we haven't used it, we don't prime it again, we may have the same efficacy, but it has not been done, and it is not how FDA has reviewed the data. So however study has been done originally and presented to FDA should be stated in the package insert. So is there any data comparing it? If you do not prime it, you're not going to deliver this right dose? There is no data.
But as far as shaking, I mean, if it's in a suspension, the suspension can separate out.
But this is under vacuum, so it's a little bit different than Zitromax suspension formulation that we have compared to solution.
Okay.
So because it is under vacuum, I doubt if there is any difference in
whether you shake it or
severity
not.
of the shaking. Yes.
Do you still tell your patients to shake? You don't tell them
No,
to shake before they
we
do
don't.
it. Okay.
And if you tell them, that's because we want to make sure there isn't any coin stuck in the mouthpiece. Because they keep it in their backpack or in their purse.
You tell them to check to make sure that
to make
there's
sure it's
nothing.
on, yes.
But you don't have them shake it.
No.
Okay. Okay.
But again, the description that you see in package insert, that's because that's how it was done originally.
Okay. And is there a difference in HFAs versus CFCs that, I mean, are spacers still important?
Yes.
With HFAs?
Yes.
Still? Okay.
Yes. Because again, the whole idea is the position in the mouth. If patients do not, if someone has a perfect technique to deliver, for MDI delivery, now an adult, great. Adding a spacer really does not change anything. However, for those who cannot coordinate their breathing, you need to have that spacer because it's all about the dose that sits in your mouth and you swallow it and it gets to your stomach and to your systemic circulation.
Okay.
Michael Lentz again. Do you have a preference, not with steroid, but between a dry powder and an HFA? And what type of patient does better with either one of those?
Again, I personally do not have any preference. It's all about patient. Sometimes we try both to see which, if they can have a good maneuver. With dry powder inhaler, as you know, it takes a good effort. So if they cannot provide that effort consistently, we use MDI with a spacer. Because again, with dry powder inhaler, unless again, they have to have a good effort, they should provide that the flow, the inspiratory flow that they need in order to get the drug delivered. We actually did a study here and we looked at, as you know, dry powder inhaler, like Advair has been approved for patients down to age 4. So we looked at patients from, I think age group was 4 to 12, and we looked at 3 different dry powder inhalers, the aerolyzer, the discus, and the turbohaler. And most of the patients could not generate enough inspiratory flow to use Pulmicort. I want to say, if I remember correctly, 70% of the patients could not.
How did you test that? Did you use like
We had
an
to connect
in-check
it.
dial?
No,
No?
because in-check dial, although you can change the resistance and match it to resistance of the Advair and Pulmicort, still there is some internal resistance that is not added to that. So we actually use the device. We put the device in a container. The container was attached to this. Yes, it was high tech. But we were able to measure inspiratory flow with the actual device. Yes. So a lot of patients could not generate Pulmicort and the flow that is needed for Pulmicort. 50% could generate what was needed for Advair. And I don't know if you have seen Aerolyzer or not, because that is mainly for adults and for COPD. That for Faradil, that one easy to do because there's absolutely no resistance whatsoever. Another thing that patients liked was you had to put a capsule in and it would make a noise when you break the capsule to inhale the powder. They love that too because that was like a sign that they took the medication. Because again with Advair especially, you cannot really tell except the dose counter, right? So they really like that. So again, it totally depends on patients. I have 4-year-old that can do Advair discus without a problem, and I have 15 years old who cannot do it. And we have placebos in the clinic, and we try. If they cannot do dry powder, we go to MDI. But when you look at the data with dry powder inhalers, especially with Flovin, you can definitely decrease systemic absorption. So if one patient can do both fluticasone HFA and fluticasone dry powder, I would go with dry powder.
Isn't the amount of oropharyngeal deposition with the dry powder inhaler
But it
much
goes
higher?
through, yes, absolutely. But it goes through first pass effect, so liver gets rid of it before it gets to systemic absorption.
Ah.
So no problem.
So it's a comparison of this
Don't
mouth
make me bring up
absorption
that
and the...
slide again. Yes.
Okay.
Yes, that's why it's not just one factor. It's not just lung deposition. It's not just deposition in oropharyngeal. It's a whole picture. Great. Anything else? Again, the most common question that we get asked in our clinic is, the growth. Remember, 1.2 centimeter. That's it. That's a worst case scenario. Another thing, actually, I was going to mention earlier, I think it's past time, but in the editorial that I was writing, I was really trying to make it very clear to a lot of providers. Remember, in the CAMP trials, patients were on Pulmicort 200 microgram twice daily for 4 years. We are supposed to monitor patients, right? So when they come, we decrease the dose. For the CAMP trial, they were on Pulmicort for the whole duration, and we added something to their medication if they were not controlled. We never decreased the dose of Pulmicort. So you need to keep that in mind when you think about clinical practice and real life situation. So that is one thing to keep in mind. That's why close monitoring, frequent visits, adjusting the dose, higher during fall, if that's the season, or summertime because of allergies, springtime, increase the dose and then decrease again. So that's how we can prevent the side effects, and hopefully we can even eliminate something like growth problem.
And we just assumed that you did it with budesonide, but we assumed that this is the same with
all the inhaled corticosteroids, because we can actually tell you about what is the equipotent doses of inhaled corticosteroids. So it's a class act.
Okay.
Definitely. Great.
Any other questions from our audience or anyone who hasn't announced their name yet?
Okay.
Okay.
Great. Thank you.
Thank you very much. And the next presentation will be, I believe, May 8th. Is that Friday, May 8th? Can we have a calendar?
Kevin's got it on the
In
calendar.
2 weeks.
Yes, in 2 weeks.
2 weeks, yeah, on May 8th. I don't believe our calendar is correct because it's listing ICS and side effects.
Right, I think we traded topics, so I think
Yes.
the topic that was for today was going to be asthma education. And so I believe that'll be the
Okay,
next one
We'll get that worked out on
by
the calendar.
UNM.
Great.
Thank you.
Thank you.
Everyone.